Thank you, Chairperson. I'd like to thank the IHPBA Scientific Committee for giving the opportunity to talk, and I'd also like to thank Dr. Mondal for accommodating my request for a change of timing. So my talk is about the newer indications of liver transplantation and the evidence behind it. Obviously, it's a vast topic, so I'll have to go through each of these things very briefly. So just to start off with, when is the liver transplant indicated? Liver transplant is indicated mainly for chronic liver disease with complications. You have a MELD score of more than 14. For acute liver failure, for hepatocellular carcinoma in cirrhosis, and for liver-based metabolic diseases. I think the bottom line is that you do a transplant when the chance of dying without a transplant is more than 10%, because that's the usual 1-year survival after transplantation. And then you also have the 50% 5-year rule, which means you would not consider transplantation for a patient if you think that the patient is if there's a less than 50% chance that the patient would survive for 5 years after the transplant. So these two criteria are one of them obviously is related to the patient risk and benefit, but the second criteria is mainly related to the fact that any patient who's waiting for a transplant is competing with a lot of other patients who are also waiting for a transplant in the cadaveric transplantation list. Now, obviously, these things are likely to change in the living donor setting, because in a living donor liver transplantation setting, the donor liver is specifically for the recipient. So there might be some relaxation of the 50% 5-year rule, but we need to be very careful when we relax these rules. So why have indications for transplantation changed? The indications have remained standard. There are now additional indications, and I think some of the reasons for that is there is an increased usage of living donor liver transplantation, not just in Asia now, but also in the West. So which means that more and more centers are carrying out living donor liver transplantation. There is a significant improvement in outcomes with liver transplantation, and this is because of improved surgical techniques, anesthetic techniques, and the way these patients are taken care of, both before the operation and after the operation. And hence the outcomes are much better than what they were maybe 10 or 20 years ago. And HCCs is one example, but even in other tumors, there is a lot of improvement in terms of non-surgical therapies, whether it's loco-regional therapies like TARE, or chemotherapy or immunotherapy for specific tumors. Now, obviously, there is an increasing enthusiasm. There are more and more surgeons now doing liver transplantations, and obviously, they all need work. So everybody is looking for more indications to transplant. Now, if we look at the newer indication transplant, I'd like to concentrate on two aspects. I mean, transplant oncology would be much more relevant to the audience here, but I think we also need to look at non-oncology indications where the indications of transplantation have expanded. And these are acute and chronic liver failure, severe alcoholic hepatitis, and transplantation for patients who were probably considered too low risk for transplant previously. Acute and chronic liver failure is basically an acute deterioration liver function in a patient who already has some chronic liver disease. And this can be related to any acute insult, and it can be alcohol, drug-induced liver injury, or an infection. And the pathogenesis involves systemic inflammation because of acute liver insult, leading to multiple organ failure. And these patients have a high risk of early 28-day or 90-day mortality. A few of them would recover, but a lot of them would die without any transplant option. Now, in the past, acute and chronic liver failure was not considered an indication for transplantation because these patients were very sick. Many of them would be in the ICU. They would be on organ support, on dialysis, on inotropes. So these were considered to be very high-risk patients for an operation as big as a liver transplant. But things have changed with the improvement in survival. We now know that patients with acute and chronic liver failure can actually undergo transplantation and have excellent results. And this was one of the earliest data which looked at transplantation for acute and chronic liver failure, and they found that patients who had a transplant had a 6-month survival of 80%, whereas patients who did not have a transplant had a survival of 10%. So there's a vast difference and a significant survival benefit with liver transplantation. Now, data has already also shown that this survival benefit extends even to grade 2, grade 3 ACLF, which means even in patients who have 3 organs which have failed at the time of transplantation, these patients do very well with timely transplantation. And the key here is to transplant them in the correct window where you have treated the sepsis, you have stabilized the organ failure, and then you have gone ahead in transplantation. And it's called the golden window. So right now, acute on chronic liver failure is a clear indication for urgent transplantation, even in the presence of organ failure, which was not the case maybe 5 to 10 years ago. The second indication is severe alcoholic hepatitis. Now, this is defined as severe liver injury without pre-existing chronic liver disease in somebody who's been drinking excess alcohol. The standard treatment has been supportive therapy with steroids, but these patients have a high short-term mortality of over 70%. Now, liver transplantation in somebody who's actively been drinking has a lot of ethical connotations because, again, the organ is going to be given to him, whereas patients who are probably off alcohol for many months and waiting for a transplant would not get it. If you take just the sickness of the patient into consideration. But again, there's been recent data that these patients do very well with transplantation, and patients who are so sick that they need an emergency transplantation are very less likely to go back to drinking again. So this was one of the first studies in 2011, which was a French study which looked at the role of early urgent transplantation for patients who have severe alcoholic hepatitis. And they found that the survival was much, much better in patients who had transplantation as against patients who had just medical support. And the risk of going back to alcoholism was 10%. So 90% of the patients remained off alcohol, even though there was no abstinence period actually before transplantation. Now, this data has been replicated in other studies. This was a multi-center study from the US, which again showed that the outcome was survival 1 year survival was 94% in these patients with about 15% of recidivism. And we have data from India also. This is data from Medanta, which has shown that patients who have severe alcoholic hepatitis have outcomes similar to patients who have chronic liver disease secondary to alcohol and who have been abstinent for at least 6 months. So the second indication is that treatment-resistant severe alcoholic hepatitis can be considered for urgent liver transplantation as long as a careful psychological assessment and social assessment is being done for the patient and for the patient's family to try and minimize the risk of the patient going back onto alcohol. And these conditions, probably living donor liver transplantation would be the best option in our country in view of the availability of access to organs. This is a more recent study. So we always said that you need to have a MELD of at least 14 to list for transplantation because traditionally the risk of mortality without transplantation at a MELD of 12 to 13 was 10%. And anything more than that, the risk of dying is more without a transplant than with a transplant. Now, this is a study which has come from the US, where what they have seen is that in the presence of living donor liver transplantation option, even patients who have a MELD of 10, 11, or 12 have a significant survival benefit of more than 10 to 12 years if they undergo timely living donor liver transplantation. The advantage of this is that these patients do not wait for long, so they do not have to go through multiple hospital admissions, needing repeated medical therapy. At the same time, it doesn't affect the cadaveric waiting list because these patients are having a living donor option. So again, in selected low MELD patients, early LDLT might be a better option than waiting for them until they develop classical indications for liver transplantation for decompensated liver disease. Now, if we go on to the transplant oncology side, first is hepatocellular carcinoma. So the first clear criteria to decide the suitability for liver transplantation was by Mazzaferro, called the Milan criteria, and we all know that it's a single tumor less than 5 centimeters or up to 3 tumors less than 3 centimeters, and he demonstrated a 82% 4-way survival with in these patients who undergo transplantation. Now, these are very restrictive criteria, and since then there have been a lot of criteria, in fact, gradually expanding these indications. You had the UCSF, then we had the Toronto criteria, the criteria based on AFP, criteria based on PIVCA, but all these criteria have been actually increasing the suitability, the criteria, the eligibility for transplantation only to small extents. Now, when we look at HCC, ultimately the outcome depends on the tumor biology, and it's very difficult to assess tumor biology simply based on factors like number and size of these tumors. So this is an example. If you take a group of patients with hepatocellular carcinoma, let's say this is a Milan criteria, you are very selective and you get excellent results. You expand it a bit more, you'll still have good results, but when you expand it a bit more, you start having patients who have recurrence. Now, this is a very crude way of selecting patients, saying if I'll transplant if the tumor is less than 8 centimeters, or I'll transplant if the tumor is less than 10 centimeters. What we need is a smarter way of selecting so that you have criteria where you can actually pick out the patients who have good biology tumors from amongst the list of patients who can have good biology and bad biology, and then transplant them. That way you can actually transplant the patients who will benefit from transplantation, but avoid transplantation in patients in whom it's unlikely to benefit. Now, we all know that while tumor load and tumor pathology are criteria for defining biology, everything depends on the tumor biology actually. So how aggressive this tumor is. And right now, the best way of assessing tumor biology for us that we have is how the tumor responds to local regional therapy. That is either TACE, TARE, RFA, whatever you have at your disposal. And this is, if a patient does well with local regional therapy and the tumor is downstage, even if it's a tumor beyond standard criteria, these patients do very well. On the other hand, even if the tumor is within criteria, but it progresses on local regional therapy, we know that these patients do not do well with transplantation. And this was a principle based on which the recent consensus recommendations from the ILTS, ILCA say that there is no point in having fixed criteria for transplantation for HCC. Each center can have their own criteria, but the basic principle should be that, first of all, there should not be any extrahepatic disease, which makes sense, because if you have extrahepatic disease, you're unlikely to have a cure with transplantation. But most important, any tumor which you think is beyond the usual criteria, if you can demonstrate that it can be bridged or downstage with local regional therapies, they should be considered for transplantation, preferably living donor liver transplantation. And this, have some more time or finish? So this is a modification now. So indications for transplant of HCC are much more liberalized now, as long as you can show that these tumors have a good biology by showing a good response to local regional therapy. The second change is in the treatment of cholangiocarcinoma. We know that cholangiocarcinoma, the resection is a primary curative therapy, which gives a 5-year survival of around 40%. But it's not always possible. It could be because there's underlying liver disease like PSC in many of these patients. There might be patients who have other forms of chronic liver disease and cholangiocarcinoma. Some of these tumors might have vascular involvement, precluding resection. In these patients, the only option we've had so far is palliative chemotherapy, which has a survival about less than 10%. Now, liver transplantation, which is the best, probably the most radical form of resection possible, is an attractive option, but outcomes have been poor in the earlier studies. I mean, this is data from almost 15 years ago, and what they showed is that outcomes for tumors for cholangiocarcinoma is much worse than transplantation for non-cancer conditions and transplantation for HCC. And for a long time, cholangiocarcinoma was considered as a contraindication for transplantation. The earliest data looking at the role of neoadjuvant therapy and then transplantation of cholangiocarcinoma was from the US, from Nebraska, who looked at radiochemotherapy and transplantation. There was a series of, I think, 6 patients who were reported and who did well with transplantation. This was followed by the Mayo study, which looked at a protocol of neoadjuvant chemoradiation and staging laparotomy to rule out extrahepatic disease, followed by transplantation. And these patients had much better response with liver transplantation. Now, this has been actually replicated in a large multi-center study in the US, and 287 patients, out of which who went through this process of radiotherapy, chemotherapy, staging laparotomy the day before the operation to make sure there's no extrahepatic disease, there's no lymph node disease, and then they go for transplantation. These patients had good outcome, and especially if the tumor was less than 3 centimeters in size, these patients had a 5-year survival of more than 69%, which is excellent actually compared to the survival this patient would have without a transplant. So liver transplantation is now increasingly an option for hilar cholangiocarcinoma, which is not resectable. And this was a study which looked at again 10 centers, 15-year period from the US, and they showed that the 5-year survival of patients who undergo liver transplantation as compared to resection, even after comparing and matching them, was 64% to 18%. So transplantation, as long as you select these patients well, the tumor is within specific criteria and there's no extrahepatic disease, and you've shown that there is a period of stability on neoadjuvant therapy, these patients do much better with transplantation than with resection. When you come to intrahepatic cholangiocarcinoma, for a long time again, these patients were considered to be a contraindication for liver transplantation. I think the earliest study which looked at a beneficial effect was in tumors which are very early, which means less than 2 centimeters in size. This was a multi-center study which looked at all the incidental cholangiocarcinomas detected on explants, and they found that if the tumor was less than 2 centimeters in size, the outcomes were excellent. What about tumors which are bigger than 2 centimeters? And this was a study by Gabriel et al. From the US. They assessed 21 patients with intrahepatic cholangiocarcinoma who are unresectable, and out of them 12 were accepted for transplantation. They were started on neoadjuvant chemotherapy and transplanted when they demonstrated stable disease for at least 6 months. And out of these, only 6 got transplanted. And this study was published, and they got follow-up data of more patients, but they had an overall survival of 83%, which again showed that transplantation in patients, even if they're unresectable, if you can select them very carefully and you can show that they are stable on neoadjuvant therapy, they have good outcomes with transplantation. So the current recommendations for hilar cholangiocarcinoma is that if it's a locally advanced unresectable tumors, if you can show that they are stable under a protocol of chemoradiation, they can be considered for liver transplantation. In fact, this is an indication for transplantation in the US right now. For intrahepatic cholangiocarcinoma, the tumor is less than 2 centimeters, then there is no contraindication for transplantation. For larger tumors, transplantation can be considered, but this is still on a study protocol basis. If they shown to be stable, to have stable disease for at least 6 months on neoadjuvant chemotherapy. The last topic is, do I have some time or?
We are out of time.
1 minute.
Okay.
Okay. Okay. So the last topic is for unresectable colorectal liver mets. So the first study which looked at the benefit of liver transplantation in these patients was the SECA-1 study published in 2015 from Sweden, where they looked at outcomes of 21 patients who underwent transplantation, and they showed that these patients had, while they had very low recurrence-free survival, which means most of these patients had recurrent disease, but they had excellent long overall survival because the recurrences were small, easily manageable tumors in the lungs after transplantation. The SECA-2 study, which looked at a very selected group of patients of 15, they showed that these patients had, if you select these patients who have unresectable disease but who have a long interval between primary tumor and metastasis, who are stable on chemotherapy, then these patients have good overall survival. The more recent development is the use of rapid procedure where you do an auxiliary transplantation. So you use a much smaller graft so that the risk of donor risk is lower, or you can use just a left-hand segment from a cadaveric liver. So you don't actually affect the waiting list mortality for other patients. And this has been shown to be equally effective in these colorectal patients. But this is still a work in progress. There are no clear criteria for transplantation. There are almost 20 international multi-center clinical trials right now in progress looking at the benefit of transplantation in colorectal liver metastasis. So to conclude, the indications for liver transplant are increasing. LDLT access means that there's no competition for deceased donor organs, so indications can be expanded. The improved survival in critically ill patients means that we can actually transplant much more sicker patients now than before. And better understanding and the role of neoadjuvant therapy to select tumors with good biology means that we can expand the option of liver transplantation to a wider number of tumors and not just HCC. Thank you.
Thank you, Dr. Srinivas.